Now I clicked start webinar. Oh, here we go. People are joining me. I got my technical consultant here. All right, the number's coming up. I think you guys have been in the waiting room and now you're coming over. So I'm just gonna sort of wait for the number. We don't have too many people here, but we are having some people here. So I heard recording in progress. So CJ, you can probably go back to dinner. Okay, bye. Okay, I'm just gonna give it a couple minutes here. I hope this works, and I think I've said it properly. I'm not the most savvy. I usually need a lot of hand holding. So I'm sitting here standing by and I'm looking at the chat box. So if anyone has some questions, maybe someone can just fire a question just to see that it works. Even if it's testing. I see we have some people here, and that was my talk. So I'll just sit here until I see some questions. Okay, I see a question. So I know that this works. And just remember, it's completely anonymous. I might see your name, actually. So I might see your name, but I'm not going to say your name. And I'm hoping that just people, as I start answering things, I'll just start firing away. The first question is, and I'm hoping I just people think of any, even if you don't have any, because then I'll keep going here. I'll stop when there's no more questions. This question says, my wife uses Gemtesa, can men use it? So what is Gemtesa? Gemtesa is a drug for overactive bladder. And men can definitely use Gemtesa. It's not going to help with regards to what we're talking about here, which is stress incontinence. That helps with urgency, frequency and urgency. So Gemtesa is for overactive bladder, as I said. Other drugs might be called Myrbetriq. The two branded drugs right now that are out there are called Myrbetriq and Gemtesa. I tend to use generic drugs more commonly because they're less hassle with insurance and usually work the same. Examples might be called Desicare or Ditropan, things like that. So yes, a man can use Gemtesa, probably not for stress incontinence. And that's that. So here's another one. Oh, Saved by the Bell. Okay, yeah, and you can ask me anything you want. You're kind enough to be here. This person is saying, can I explain about ejaculation after a prostatectomy? Ejaculation after a prostatectomy and removal of the seminal vesicles. I'm not going to figure out how to import those slides back over, but the act of removing a prostate, so we can talk about this a little bit, sure. Removing a prostate, because I said the prostate is sort of a junction valve where the reproductive tract joins the urethra with the urinary tract. The seminal vesicles, which are the structures that make semen, are actually connected to the prostate. They drain through the prostate into the urethra. So for us, that's also where the vas deferens from the testicles also join in that location. So if you've had a vasectomy, you've had the vas cut in the scrotum, but in reality, that goes all the way to your prostate. So we have to sever the vas there, and we have to remove the seminal vesicles. So therefore, if one has a prostatectomy, they no longer have the structures that make semen. And for this reason, you'll still have an orgasm, you'll still have the pumping feeling, but you won't have any semen shooting out, nor will you have sperm in the semen, because you've had the ultimate vasectomy at that point. So that would be the answer to that question. Another question is that yeah, okay, good. The issue here is not leakage. This person doesn't leak. It sounds like this person just has a lot of urgency to go to the bathroom. So this is not a stress urinary incontinence question, but I'm happy to answer it. He says, sometimes my bladder explodes, which I think means, oh my God, I have to go all of a sudden, and I can't get to the bathroom in time. So that is leakage, just so you know. I mean, you're leaking, but we call that urge incontinence, not stress incontinence. Urge incontinence. What do we do for that? Well, the problem there isn't the bladder neck. It's actually the top of the bladder squeezing prematurely. So it's not taking directions so much from the spinal cord or the brain at that point. It's just sensing fullness and it's going just like a baby does. So what we have to do for those people, we wouldn't want to shut down the outflow because you would be exploding and you couldn't go. So these procedures wouldn't be for that problem. we'd have to do things to try to calm the bladder down. That's, for instance, that drug Gemtesa or Mirbetriq would be medical examples of trying to get the bladder to calm down. Also, there are nerve stimulator devices that can be implanted, or injecting Botox into the bladder, for instance. These are more of the procedural solutions to move on to if medicines aren't working. So that's called urgent incontinence. It's terrible and you might need to wear pads, but different type of incontinence. That's what we were talking about in the beginning. And then here's the next question, which is, this person had a prostatectomy in 2021, and he is, quote, continent, and he's living a regular lifestyle, and he cycles. And if it's who I think it is, he cycles a lot. But the problem is during very vigorous hikes, maybe he will fill a pad after a mid-sized pad within a 1 to 2 hour hike. And that's what I'll hear a lot. I'm pretty active myself. And so that's your mostly continent. And, you know, if we wanted to sweep that under the rug, we would say, you know, hey, you're dry. What are you worried about? You're basically dry. And your problem is just that you leak a little bit, you know, after, you know, you hike a lot. And what's the big deal? And I'd say, well, you know, I know who that patient is, and I know how big of a deal that is to his lifestyle and his happiness. And so if a person says, look, I leak some, it's a function of how much it bothers you. I don't have a magic medicine that's going to help that. That's some strenuous hiking. And so we talk about stress incontinence, pushing down on that. But that would be a classic person that might say, if they were bothered enough, they might say that they're bothered enough to do a sling. Okay, that would be a classic sling patient. And that's not something I talk them into, but I'd say, look, if that's a big hindrance to your life and you're annoyed by that, I certainly would be willing to offer something as simple as a sling procedure. It would probably solve that problem. It's just a function of how bothered they are and if that person wants to live with it or not. And now we're getting a question that really doesn't have much to do with this talk either. And this is one where I have a strong opinion about this. It's called aquablation. So I'll be happy to talk about it here, but I'm just going to talk about it a little and then invite you to go to my website, dcurology.net, and go over to the educational videos section on enlarged prostate. And I talk about aquablation in great detail and why I'm not an enormous fan. But just in case everybody might be interested in that question and everyone can participate. Aquablation, now we're talking about enlarged prostate treatments now. I guess there's a tie into this because every now and then someone will leak because of an enlarged prostate treatment. But aquablation is sort of a machine that is, if you're old enough to know what this is, I'm old enough, so you're probably old enough to know what a water pick is. You know, those used to be very popular to floss your teeth with a jet of water. It's like a water pick times 100. It's a very strong jet of water where a computer can kind of set where this goes in your prostate, and it sort of blasts or destructs your inner prostate tissue. You have to urinate through the middle, and it can be an effective treatment. In my hands, though, when I evaluated, I got trained to do it. I thought this is minimally invasive. It's right up my alley. But the problem for me with aquablation is that you're still in the operating room. You're still asleep. You generally always have to stay overnight because it's very bloody. There's no hemostasis to it. And it tends to be quite bloody. And at least in its initial versions, there was about a 5% risk of having hemorrhage and shock and have to go back to the operating room emergently. And that's just not something I generally see with alternative procedures. The only claim to fame, I think, of aquablation is that it markets itself to say you can set the computer to spare the front of the prostate that would have to do with semen ejaculation, and that's a problem with enlarged prostate procedures. And so if patients have that as their highest priority, trying to maintain their ability to ejaculate, and some patients do, then they can accept what I consider a lesser or subpar treatment for that problem, that there's no reason to think it would have the same longevity as its competitors. And so that would be the only reason to have an aquablation. Or if you're seeing a urologist that is not adept at the highly specialized operations that we do for very big prostates. I am adept at that with robotic surgery, so I haven't needed to adopt it. So it is effective, I don't use it much in my practice. I certainly could. I go to Reston Hospital, GW has it. I could do it in a heartbeat, but I don't favor it over the things that I offer, but it's a individualized choice. And now this is a great question, and I'm glad someone was listening, and I think it definitely deserves explaining. And I gave my opinion about something, which is Kegel exercises. So let's talk about those. I used to call those turtles. I used to make a really big deal of teaching patients those, and I have formed my opinion as to how important those are, really from the fact that you know, I've done thousands of prostatectomies, and I was the first to do it in the Mid-Atlantic area. So what was very unique about my practice is I was doing 10 prostates a week, 10 prostatectomies a week, and I was still seeing all my patients back. So my research thrust tended to have more to do with the outcomes, meaning impotence and incontinence, because I was the one helping you. I was the one taking your catheter out. I was the one talking to you and then seeing you later and trying to correlate between what seemed to matter and what didn't. And what I know is that Kegel exercises, which are for women, which are designed to basically have you rhythmically squeeze your sphincter. You can do it now. I'm squeezing it. You can't tell. I'm squeezing it. Again, women need Kegel exercises because women leak because of support issues. They may have had childbirth with age. Their vagina is not holding their bladder up like it used to. So the concept of rhythmically squeezing, or, you know, I call it taking your vagina to the gym. Every time you're at a traffic light, doing a set of 20, it's like trying to bulk up the muscle around your bladder. Now, if you heard what I said about why does a man leak after prostatectomy, it doesn't have anything to do with the muscles in his pelvis. It has to do with his bladder neck. So now that being said, if you are getting a prostatectomy by me, you'll see that we still make a big deal of filling your bladder before we take the catheter out, trying to get through to you as to what is your sphincter, how do you squeeze it, how do you hold it, and we need you to know how to do that. But what we tell patients is not to sit there and do a set of 30 or 40 or anything like that, because I don't think that helps you at all. I tell you to apply the act of squeezing and holding for 3 seconds to your life, because I'm trying to get you to leak less when you change positions, stand up, sit down, until your bladder neck fixes you. So it's not going to fix you. Now, that being said, if someone doesn't know how to use their sphincter, they just simply don't know how to volitionally do it. We'll see people, I'll say, squeeze your sphincter, and they'll go, or they'll suck in their gut or push out their abdomen. They don't understand what you're saying. They will be helped by learning what I want them to do. And I might have to send them to a physical therapist to learn that act of squeezing their sphincter. And that act is called a Kegel, or Kegel exercises, which means doing sets like this. I have not found in my practice for that to be helpful at all. You say, why does everyone tell you to do it if they're ineffective? I mean, I think one simple answer is they've been around. I mean, they're not going to hurt you. And commonly, it's just not, I don't find a lot of people, frankly, with my experience, where they've done this many prostatectomies, but they've also helped all their patients with incontinence. And so it might be the surgeon doesn't see you afterwards. So they say, okay, it'll sound like a good idea. Or the PA or the rehab person isn't the one that took your prostate out, so doesn't know either. And I think that's why everyone's told to do it that way. I tend to have very strong opinions about what I'm trying to do to help my patients, but it's generally garnered from my experience. That's all how I can answer that question. The next one says, we only have a couple more, so if anyone can think of any more, that'd be fine. That after prostate removal, is it more difficult to have a sling procedure? No, not at all. In fact, that's who usually gets a sling procedure, is someone who's had a prostatectomy. And if you remember, again, you know, you're going to have the bladder and then the prostate and the urethra. We're going to sew the bladder to the urethra, but the sling is going to be attached further downstream. So it's not going to be inside of you where your prostate is, where the prostatectomy was performed. It's going to be done not by going through your abdomen, but a little incision under your scrotum. and that's where we're going to get to your urethra. So no, it's not at all more difficult to have that after prostate removal. In fact, that's exactly who it's for. And then the last question I have here, and if that's the end of them, well, I'll think of any other random thing I can think of, and then we'll call it a day. But we'll answer this one. What pad do I recommend? Or should pads be avoided? No, pads shouldn't be avoided. Pads are what you definitely need if you're leaking. And that's what you live with. I try to avoid those clamps, and I try to avoid those condom catheters, because again, I just think those are just extreme measures that are just giving up. But I mean, it's up to the patient. You know, the pads come in different brands, and there's knockoff brands. People generally find them on Amazon. The only thing I can say about that is I know that there's a tendency for people to wear these pull-ups. And that's what I recommend right after, say, a prostatectomy or something like that, a pull-up. Because you don't know what to expect and it's easy to do. But I think that mentally, as a person starts to leak less and less, I will push patients to stop wearing pull-ups. Because again, you just kind of get used to it. You say, that's my new underwear. And I usually say, that's just not what you bargained for. You shouldn't, you should wear as little pad as possible. I actually just thought of I could actually, I'll talk about one more point here. Even though no one has asked about it, but I generally say, why don't you get down to the smallest pad that you can, wear the right underwear that can hold it. If you're leaking more, they're like cup shaped, and then as you leak less and less, they look more like a woman's thin maxi pad. But generally, I'm trying not to have men wear diapers if they're not leaking that much, because psychologically, it's just the more you wear, the more of a pad you wear. Generally, the more you're going to leak, because the more you're going to be worried about it. I want patients to be a little worried about it, so they have to think about using their sphincter. So that's a good adage I can put here in the question and answer period. When a guy gets down to one pad a day, let's say after a prostatectomy, that person, I'm usually pushing them very hard to stop doing it. It's hard to get rid of that last pad. It's because you just get so used to wearing it. We call that a confidence pad. And it's just something that you have to decide, do I really need it? If a guy's wearing one pad a day, I already know they're not leaking at night when they sleep, so I say don't wear it when you sleep. And I already know they don't usually wear it much in the morning, so I say don't wear it in the morning, only wear it in the evening. So that's a good thing to point out about pad usage, is that I always say the more you wear a pad, the more you'll leak. And as long as you wear a pad, you will always leak. And that's really true. When a person's close to being able to be out of a pad, they need to really try not to wear the pad, so that they have to be worried. They have to think about squeezing their sphincter when they're about to stand up. They have to be concerned, and then they'll realize, hey, wait a minute, I had to run out and go get coffee. And you know what? I forgot a pad, and I was worried, but I did it. And that's usually the eureka moment that people need to realize that they can actually get out of them entirely. So I'm not a big fan of people wearing them for the rest of their life just for confidence. And then I'm just gonna, I think one good point I could throw out here that I think might be very helpful for anyone who's ever had a prostatectomy, who might even be having incontinence and doesn't know what to ask here. Hopefully it's a pretty straightforward discussion of a straightforward topic, and I hope what you get from it is that you don't need to leak. There's no reason to wear all these pads and spend all this money. You may as well just get it fixed. And so I'm going to comment on now, since I've run out of questions, but I'm going to pretend someone asked me, hey, talk me through the stages of continence after prostatectomy. So how do I know I'm on the right track? And that might be helpful to people, even who didn't attend tonight and might watch this on my website. So let's talk about the stages of continence after prostatectomy. So stage 1, and this is how you know you're doing better. And these stages commonly get to almost the final stage within 3 months or so. It's not overnight. And a lot of people will say, but I'm still leaking and it's bad. But when I can tell them about the stages, they'll realize they're making progress. And I think that helps people psychologically. Stage 1, the big event stage 1 is, I made it through the night and I didn't leak. That's going to be the first thing. That is the big, accomplishment. I made it through the night and I didn't leak. That's stage 1. And then stage 2 is, I made it through the night and then I actually felt like my bladder was full and I had to get up and go urinate. And I went over to the toilet and I urinated and I didn't leak on the way. And that's stage 2. And those things usually happen pretty quickly. Stage 3 is those things plus, well, not only did I get up in the morning and urinate, or once or twice at night and urinate, like men do, the next stage is that I actually don't leak much, in the morning. I have my coffee, I urinate, that's all good, and I only start leaking after noon or so. That's stage 3. And then stage 4 is usually I'm dry all day really until I start to get tired towards the end of the day, or if I drink red wine. A lot of people say red wine for some reason in the evening. That's when I'll leak. So I usually try to say, then wear the pads according to what stage you're at. And if you've made it to stage 4, then just put a pad on at noon and go from there. That kind of thing. I mean, obviously stage 5 is to say, okay, now basically I'm only leaking like the gentleman that is hiking in the Alps and starts leaking a little bit. That's just some stress incontinence, and that's time to get out of pads. So those are the stages of continence. It doesn't happen overnight. Most people are dry or to that one pad where I'm giving them a motivational speech to get out of the pad at 3 months. And and that's the bottom line. And another good adage to point out is there's no amount of incontinence that it takes for you to say, I'm bothered. That's another philosophy I always have. If something's limiting your life, if something's just making you feel bad about yourself, you don't have to leak a ton to say, I want to get it fixed. You don't. I've put slings in people that basically didn't wear pads, but they only leaked, and this is a common complaint, when they were sexually excited. They only leaked when they were trying to fool around or have sexual relations. And there's a reason for that, is when your body's trying to get you an erection and your spinal cord tells everything down there to relax so that you'd be able to ejaculate, and it's causing you to leak some. And then so I put slings in people where it was just that. It was, I leak when I'm with my wife or my partner. That's good enough for me. I'll do a sling for that. I've had people say I leak when I play golf and I don't like it. It's messing with me. So that's another adage. You don't have to leak a ton to say I'd like to be fixed. And so it's usually just I'm used to it. It's an errand on my list and people don't get around to it, and I hope that they do. I'm running out of adages for me to think of. So thank you for your questions there. I'm going to wait just a couple secs here to see if anyone wants to put any more comments in the chat room. I, at this point, think I've seen them all. If it's something that is more complicated, it's very easy to see me. You just go to dcurology.net. There's videos of everything I do there. Easy, and I'm happy to talk to you individually in the office. Otherwise, I think I'll just say thanks for sticking around till the end, and I'll see you soon. I'll be giving a lot more talks moving forward, and stay tuned. Oh, one more. It says, does a sling last a long time? Oh, suddenly I got one. Okay. Does it last a long time? It normally lasts forever, to be honest with you. I am starting to see a couple people that as they get older, I mentioned that in the talk, they're starting to say, hey, I leak a little, kind of like a pad a day or less than a pad a day. Anyway, it's not something I usually have to redo. It's usually you do it, and the vast minority will say that it came back. Okay, that was a teaser. I got one at the last second. I should have mentioned that. Same thing with a sphincter, by the way. The sphincter is usually something that lasts forever, but there is more of a revision rate with a sphincter. There can be, particularly in radiated patients, where that cuff goes around the urethra. Sometimes when you get older, the urethra kind of shrinks, and it's like you lost weight and your belt is now not the right fit. And sometimes all we do is just tiny little incision, remove the old cuff and put a smaller one in. That's called resizing the cuff. And sometimes it's 15 years later, something like that, and something sprung a leak. But I find invariably that the patient may have waited forever to get something done, But once they do get something done, they're always going to say, fix that. I want to be dry again. So that's how I know it's good to be dry. It says, when can you do exercise or sit-ups after a prostatectomy? I've got another one here, and I would generally tell patients after a prostatectomy that they're free to do whatever their body tells them they can do. They're free to do whatever they feel like they can do, usually within 2 weeks. There are no huge incisions. You do have a little incision by your belly button, but it'll tell you if it's sore. And if it's not sore, some light sit-ups at that point are not anything I think is going to cause a big issue. I usually say a patient's free to do what they want. I have to cover myself about driving at 2 weeks. And so any exercises, I'm just saying, follow your body 2 weeks. I've not really seen anybody have trouble after that. Okay, now I'm going to give the last call. Okay, I got another. How long does it take the abdominal muscles to heal? Well, it's like heal to the degree that your body doesn't know anything happened. That might be a month or two, but heal to the degree that you're free to do what you want to do and let pain be your guide. As I said, that's going to be, in my opinion, about 2 weeks. Your body will tell you. Right now, my Achilles is sore, and it's getting less and less sore, thank God. But for a long time, it was telling me, hey, leave it alone. Don't stress it or you'll be sorry. I listened to it. I'm starting to get back into things, and I think you do the same thing after surgery at 2 weeks. This person's actually trying to be specific of the holes in the muscle wall. They're very small holes. The ones that need closing, I close with a thick suture. So again, I'm going with the 2-week answer there. This is different than if you have a major surgery or hernia surgery where they're really trying to let things heal. Answer to that in terms of healing, I'm going to say is 2 weeks. Okay. Last call. Anything else? Looks like we're good. Okay. Thanks for those last minute ones. I like answering questions all night long. I have no problem talking. So anyway, see you all for future talks on this stuff, other stuff. There will be a longer and longer educational video section. That's something that helps my patients a lot, and helps me help you. Okay, I'm going to try to figure out how to get out of here. I'm going to hit end, and I hope to see you all in the office, and I hope this helped. Talk to you later.